invitation to, to be as our lecturer in this webinar. I am also thank Dr. HafeziMotlagh, my colleague, to be our moderator in this webinar. Uh, Thank you very much. Please, Dr. Hafezi.
Good afternoon, everyone, and welcome to today's webinar. We are delighted to have you all here and truly appreciate your time and interest. If you have any questions, feel free to type them in the chat box at any time. We'll address them during the question and answer session at the end. Now, it's my great pleasure to introduce our speaker, Professor Abdulhameed Alsarraf, who is a board-certificated oral medicine specialist. He earned his Bachelor of Dental Surgery degree in the UK, then advanced the specialty training in oral medicine at the University of Western Australia. Dr. Alsarraf is the author of Oral Medicine Clinical Guide, which features over 200 clinical images and provides a detailed stepwise method for diagnosing oral lesions. He also completed a fellowship at Queen Mary University of London and the Royal London Hospital, where he currently serves as a researcher in oral medicine. He is currently the scientific committee coordinator of Kuwait Dental Association. Professor Alsarraf, thank you so much for being with us today. Dear Professor, the stage is yours.
Thank you very much for this introduction. I'm happy to present this webinar for the Department of Oral Medicine at Tehran University of Medical Sciences. It's been a while. I haven't done online webinars. The last one was about 3 years ago during the pandemic, but here I am presenting to you from Lesion to Malignancy. I'll spend a few moments putting up some disclosures that I have and highlighting the last point in this slide, which states that all cases are my own. I have been piling these cases up since 2015 when I started my specialty training in Australia. And they represent my own opinion about the conditions and their treatments. As you may know, many oral medicine specialists across the globe have different opinions on how these lesions are treated, but here is just a point to make that this is my only opinion. So the cases are piled up from these buildings. So most of the cases were seen in the Oral Health Centre of Western Australia in Perth. This is the largest state in Australia where lots of patients come in with lesions that require treatment. And the other building here at Royal London Hospital, where I spent my fellowship, as you've heard in the introduction. And now I'm working in this building. It's in the north of Kuwait. It's called Jahra, as well as a part-time specialist in south of Kuwait at the Kuwait Oil Company Hospital. Okay. So here we go, 3 years at this building in Western Australia. It's been tough, but I guess it's worth it. And now I'm here since 2022, seeing patients in Kuwait with lots of different conditions and etiological factors. So since I'm here with you electronically via a webinar, I might as well just show you where I am at the moment. So this is Kuwait here. We are close to Iran. We are borders with Iraq and Saudi Arabia, and most of the cities are near to the sea. So here I am here. If you can see, I'm pointing in the map here. This is Al Jahra, where I work for most of the days of the week, and this is north. This is probably the furthest where cities are, where people live, and here it's just the desert. And then the part-time job I have is down south here at Al-Ahmadi. Okay, so here where I work, and my house is right in the middle here. Okay, so I'm at the moment I'm here talking to you, and welcome anyone who wants to visit. Kuwait is a nice country. Okay, so I've been talking about oral medicine throughout the world. I've been visiting many countries. Jordan was the latest, it was last month. India, I've been to Yemen, believe it or not, as well as the United Arab Emirates, Palestine. Obviously, I'm from Kuwait. I've been to Iran twice, believe it or not. And here is the first time I've been to Iran. I had a selfie with Azadi Tower in 2023. So I think it's the right time to start talking about our topic, oral cancer. I'll share with you some facts just before I stroll on. Is everything is fine with the sound and the slides? Everything is working fine before I crack on?
Yes.
Okay.
Okay, good, good. Okay, so oral cancer is defined as any cancerous tissue growth involving the lips, tongue, salivary glands, buccal mucosa, floor of mouth, and gingivae. Okay, so this was highlighted by the WHO as oral cavity subsites where this disease occurs. We know very common etiological factors, including tobacco smoking and alcohol consumption. But obviously, there are lots of other risk factors that we will talk about in a minute. So let's have a look at these cases. So all of these are advanced cases of oral squamous cell carcinoma. We can see the necrotic tissue involving the floor of the mouth here, a chronic ulcer followed by necrotic tissue and ultimately growth. Okay, so the stained tongue is due to the use of smokeless tobacco, but we're talking about the chronic ulcer involving the floor of mouth, in this case on the left. On the right, we can see an eaten tongue with an extensive growth with mobility of teeth. So this is another sign that we should look at when conditions are very advanced in their stage. Okay, so we know that the survival rate is 50%, and we know that delayed diagnosis is associated with high morbidity and mortality. So neck metastasis is one of the signs to tell us that the prognosis of this patient is fairly poor. Okay, so let's look at some more cases. Here is a lump at the floor of the mouth, as well as a lump on the tongue, fairly large lesions appearing suspicious for squamous cell carcinoma. Here's another one, and this one where the lesion is punched out, we can know the difference between it and the squamous cell. This is verrucous carcinoma arising from a large leukoplakia. In this case here, we see a mixed red and white patch with a central ulcerative lesion forming a kind of a lump right in the left lateral tongue here. Okay, so detection is not always easy. We should actually move the tissues away, especially in elderly patients. We have to look carefully for these lesions. Sometimes they appear without any symptoms, so the patients don't complain about anything. So during routine examination, we can detect those. So here's an example by retracting the cheeks and moving the floor of mouth and the lymphoid tissue away. We can see a small lump there. Okay, so this is a good point to note. Another verrucous carcinoma case and the large tongue case. From these cases, I think we can gather up an idea of how these lesions appear and what's the common clinical characteristics. Sometimes we see patients being prescribed antibiotics because of the swelling extraorally, but if you look in the mouth, you can see the same growth-like features and severe ulcerations indicating squamous cell carcinoma. We see many cases here in Kuwait using smokeless tobacco because we have lots of expats and workers from India, Pakistan, and Bangladesh. So here's one case with a verrucous carcinoma as well, involving the left buccal mucosa. Okay, so bleeding on presentation is another factor that we should discuss. When it's the tissue is necrotic and the disease is advanced in its stage, a patient could probably come up with a bleeding tongue like this one. And this is another lump here on the right lateral tongue. So there's lots of cases. Sometimes even patients deny visiting a specialist or going to the dentist because they feel that there's something wrong. So consultations are being received via WhatsApp as well. So this is one example here. Let's see if the video works. Okay, so this is just telling me that there's something wrong and they require a consultation for this. Okay, so there are other types. We'll go through them quickly before going on to the precancerous phase of this very important topic. I actually appreciate the department for looking at people who's interested in this topic to speak about, because it's kind of good to always keep this awareness level to the top to our colleague dentists, because they are the ones who refer those cases. So let's look at the types of oral cancer. We have oral melanoma. They are rare, but they do appear as aggressive diseases in the oral cavity. They often appear as large diffuse lumps. This is a plasmacytoma case, which was detected on radiographs, radiolucencies, as well as the intraoral lumps, as we can see in this clinical photograph here. They do have good response to radiotherapy, so this is good about plasmacytomas involving the oral cavity. Okay, so what appears before all of this? So we spent probably 5 to 10 minutes talking about oral cancer, where it's too late, I guess. We do want to see those patients before that stage, ideally, to prevent oral cancer transformation. So what appears before all this is our well-known term in the literature, oral potentially malignant disorders. Okay, so pre-malignant oral lesions have been widely distributed as clinical definitions, as well as research through many well-known journals. And probably this is the one that I came across in 2020, I guess, where there was an update on the list of oral potentially malignant disorders. So here we go. Leukoplakia, erythroplakia, PVL, proliferative verrucous leukoplakia. I'm sure we've heard about this before. Oral lichen planus, oral submucous fibrosis, palatal lesions in reverse smokers, lupus erythematosus, epidermolysis bullosa, dyskeratosis congenita, oral lichenoid lesions, and graft versus host disease. I currently give talks to the oral medicine postgraduate students at Queen Mary University of London. I always highlight that or this particular topic is very sensitive, and it actually requires several series of lectures. So covering all this in 1 hour would be obviously impossible. So we will look at probably 4 or 5 of these, which is nearly half, with lots of clinical photographs that from my patients to see how they present, and probably see what's relevant to us as specialists at this point in time, and what are we doing to them. So I'll start up with erythroplakia, which is defined as a red patch that cannot be characterized either clinically or pathologically as any other definable lesion. Okay, so a red patch, you exclude trauma, you exclude other conditions that could present with red patches. This is another case, and I remove them. Okay, so research and evidence tells us that most of these are carcinoma in situ at biopsy. And from the ones I worked on, it's actually true. Okay, so severe dysplasia is, or high grade dysplasia is one of the results that we usually get with erythroplakias. Okay, so we'll move on to leukoplakia. Erythroplakia is a bit more less common, let's say, compared to leukoplakia. So if I see a leukoplakia every week, I would probably see erythroplakia every 3 months. Okay, so the definition of leukoplakia states that these lesions are predominantly white in color. They could be a patch or plaque that cannot be characterized clinically or pathologically as any other disorder. Oral leukoplakia carries an increased risk of cancer development either in the oral cavity or the head and neck region. Okay, so I do have lots of cases that I'd like to show you from my humble experience. We can see thin leukoplakias. I have a few moving towards verrucous hyperplasia. Moving towards oral squamous cell carcinoma. Okay, so while the evidence and literature is telling us that this is a transformative disease, my opinion is to intervene during the earlier stage that the patient appear with. So if the patient appears with a thin, smooth leukoplakia, I think we should intervene. Patient appears with a thick, fissured leukoplakia down the middle third here, I think we should intervene. When it's verruciform leukoplakia, I think we should intervene. I don't think we should wait for it to be speckled or an erythroplakia to decide we have to do something for the case. Okay, from me traveling around the world and listening to concepts of how the clinical experience differs from one place to another. I mean, I'd love to know what is happening and what's the opinion of the specialists from Tehran to be able to discuss the good and bad about the process. But for me, I would say we should intervene. Waiting for it to transform is not a good idea. Okay, so I have been listening that this is an approach by some specialists around the world. Okay, so histopathologically, this is also evident. Okay, so as much as these conditions progress, as much as the grade of dysplasia gets higher. Okay, so while the grade of dysplasia is higher, we're getting close to oral cancer. Okay, so we did mention that there are other risk factors, and I've put a small question here. It's increasingly being detected in the Middle East. Why? So instead of listening and reading about the risk factors and the prevalence of smoking in countries, I can believe my eyes and say that probably 1 in 10 don't smoke in Kuwait. 1 in 10 don't smoke in Iran. 1 in 10 don't smoke in Egypt. So this is a, a very bad percentage. So if we say 10% from the population don't smoke and 90% smoke, then we have a problem. Okay, so and the problem is much more higher than me talking about smoking. It's the issue is a bit political. The issue is kind of goes towards awareness problems and all of the others. But it's not only smoking. It's lots of things. It's alcohol. It's bad nutrition. It's even more getting towards women smoking. Okay, so at least talking about here in the Gulf countries, surrounding Kuwait, including Emirates, Saudi Arabia, a very large country, Bahrain, Oman. The number of women who smokes, Kuwait as well, the number of women smoking is being increased. Okay, so the number is increasing, which means the prevalence of these lesions are getting higher. Okay, so this is one thing that we should highlight. And obviously, the number of expats coming from around the globe using smokeless tobacco as a habit. So this also increases the number, obviously, of cases. So let's have a look at those cases. I'll spend 1 or 2 minutes flicking through those clinical photographs. Sometimes they're very easy to see. I mean, the the lesion shouts out to you, telling you, "I'm here. You can see me." Even with that, dentists do miss them. So this is a problem. But here we go. Sometimes they're quite bright. You can see them clearly. Sometimes they are large. They involve the full length of the lateral tongue. And sometimes they are multifocal. So they involve several sites. So if you miss one site, then you shouldn't miss the other site. Okay, so here we have the gingiva being involved, the lingual gingiva, as well as the floor of mouth in one case. And here where I want to spend time talking about proliferative verrucous leukoplakia and this particular case. I've seen this 60-year-old female who never smoked in Australia in 2017. So that's 8 years ago. So we have gingival leukoplakia, right buccal mucosa leukoplakia, and palatal leukoplakia. So very large, very extensive, and very aggressive. When I've seen her in 2016, that was 2016, so that's 9 years ago, progressing through 2017 with a newly formed lesion within the large lesion. Okay, so this wasn't there before at the first visit, and biopsy confirmed oral squamous cell carcinoma at this particular point after 6 months from initial examination with a very large 28 millimeter tumor. And this is the PET scan showing the tumor with neck metastasis as well. Okay. Problem with this lesion or this condition is the high recurrence rate. So if you can see, this cancer has been removed very nicely with the radial forearm flap. Patient was being monitored, reviewed, and she was fine after the surgery. The problem is the recurrence. Okay, so this is the same patient. She came back for her review, and we've seen those lesions appearing again within the graft. Okay. Okay, so I want to speak about the other condition, submucous fibrosis. Here we can see the number of non-Kuwaitis compared to Kuwaitis, and we can see the majority are Asian or African. Okay, so here comes the patients where the risk factor of smokeless tobacco is very common. So here we go, patients using smokeless tobacco in the inside of the cheeks several hours a day, causing submucous fibrosis as well as extensive leukoplakias. So mainly it's the pan mixed with areca nuts and lime that causes this clinical presentation that you're seeing. Okay. This is another feature that I come across. Tense and fibrous bands. This is what I wanted to show. And usually it's painful and debilitating for the patient not being able to open wide and eat properly. Okay, so there's a big debate about whether oral lichen planus is actually potentially malignant, and it's still going in the literature whether this is an actually potentially malignant condition. It's in the list that I showed you. It's worth showing a few challenging cases that I believe continued inflammation leads to progression of oral lichen planus to oral squamous cell carcinoma. So the first paper about lichen planus was published in 1866, as you can see here. Okay, so firstly detected as a skin condition, but then they've seen oral cases in combination with skin conditions, and here we go. We can see lichen planus under the microscope as well with certain features. So here we have many forms appearing in one condition, and here where it becomes challenging. Okay, so plaque type, continued ulcerations, redness, and all of these features makes it difficult treating the patient and makes the condition progressive. Okay, so here's a palatal ulcer, very large ulcer, that was being managed by maxillofacial surgeons initially, incorrectly, by having lots of antifungals and then systemic antifungals and then antivirals and then all of whatever is available. But this is all causing deterioration of the case. We have injected intralesional steroids because we know this is lichen planus. I from memory, I think she had buccal mucosa lesions as well, some reticular lesions that indicates that this redness is also lichen planus, but we did have a good response. after intralesional steroid injections. Okay, so here we go. We have reticular lichen planus, we have erythematous lichen planus, and a central ulceration in this buccal mucosa. Bilateral. Topical therapy allows healing. This is the left one here. And these are some reticulations in the lip. And the idea about presenting this case is that it might be easy to treat those conditions with topical therapy alone, making them stabilized or actually healed very well instead of deteriorating the case. So proper diagnosis is important because progression of these lesions do actually allow for continued inflammation and squamous cell carcinoma development. Okay, so actinic cheilitis is another condition that I wish to spend time to talk about. Is damage from sunlight. As we know, lower lip is the common subsite for the development of actinic cheilitis. And as you can see from the map here, from the kilowatts of solar energy, we can see that Australia has the highest actually, as well as the part from South America. But here we can see that Australia has got around 3,500 of kilowatts, and this is where I spent time during my postgraduate studies. This is the exact location of Perth, Western Australia. Okay, so they are aggressive and they tend to progress to squamous cell carcinoma. And as you can see, treatment of it is extensive. Okay, so I only have one case that I didn't come across in my 10-year experience. It's probably because I don't have people practice this habit here in Kuwait. I don't see them. I don't think they exist. So palatal lesions in reverse smokers is another condition that's in the list. And I asked one of the group members that I joined in the World Workshop on Oral Medicine, the seventh one, which was in Sweden, okay, in 2018. Here is me at the top left, and Dr. Akil is a pathologist from India. So I asked him to send me a case with palatal lesions in reverse smokers to put in my lectures, and here we go. So we can see inflamed minor salivary glands, these red dots, and then the palate of this patient. And I did mention the courtesy of Professor Akil, who helped me complete the lecture with this photo. Okay, it's interesting. I mean, palatal lesions in reverse smokers. Why would you flip the cigarette and smoke it the other way around? Okay, so it's kind of interesting to me. Okay, so what next? I think intervention starts with a biopsy. There's lots of adjunctive tools that I'm sure you came across. Staining, light-based tools, and cytology, amongst others. But I've spent a few years working on oral brush cytology. And the brush is this one here called Orsilex. And this was my thesis when I used to specialize in Australia. So A bit about what light based detection system helps with. Okay, so here's a case. Moving on to an actual case that I worked on. So the Velscope suggested that the left aspect of the floor of mouth is worse. Okay, so here we can see the biopsy was done at this site, which gave us a moderate dysplasia histopathological diagnosis. And here's the brush biopsy technique that I used. So I used to brush the lesion, immerse the brush in a preservative, then moving on to the thin prep processor with a cytology slide that helps looking at the pathology clearer. Okay, so here we go. The lesion is brushed, and pinpoint bleeding is important to make sure we have a full thickness sample, so to the connective tissue. And we have modified the Bethesda system, which is used for the cervical cancer up until this stage. So we have looked at specimen adequacy, if the specimen is adequate, and we looked at epithelial cell abnormalities. So this is the kind of number of cells that we get with brushing the lesion, and this is how the cells appear. So detecting the abnormalities and the difference between a normal cytological cell and a dysplastic one, and as well as squamous cell carcinoma. We'll look at some examples here. So if you see the top of the slide here, we can see an increased nuclear cytoplasmic ratio compared to a normal cell here. Okay, so this suggests that this lesion is dysplastic. And when it comes to squamous cell carcinoma, then you can see the cells are clumped together cytologically. Okay, so we did a systematic review talking about brush cytology. We've seen 36 studies back in 2017 exploring the utility of oral brush cytology. And then we have used liquid-based oral brush cytology in nearly 100 patients, 100 cases here, 100 leukoplakia cases. And we have seen an accuracy rate of 75%. Okay, so we used to compare the cytopathological correlation. So we used to compare the cytology diagnosis with the histopathology diagnosis, and the accuracy rate was 75%. Okay, so what next? Back to our focus of discussion is biopsies. Okay, so I often work on these, and obviously analyze them, assess them, and diagnose my own cases. So I achieve a proper histopathological or clinical pathological correlation. So here we go. I'll present a few cases of biopsies taken. I sometimes use punch biopsies in critical areas, such as this leukoplakia here in this elderly female. And sometimes I use laser to remove the lesions. And why do I do this? I remove them to detect dysplasia and prevent malignant transformation. So this is my reason for removing them. I also have a question here. Do they progress? This is the same case. The erythroleukoplakia extends from posterior lateral tongue to the floor of mouth to the anterior ventral surface. So I'll just put the question again. Do they progress? So I bet this was just a white patch. And throughout the years, progression appears. I'm sure you remember this case. It's been 10 minutes since I presented this. So this patient came to me and said, 5 years ago, it was just this patch, but the dentists usually prescribe antifungal for 2 weeks, and then they asked me to, go away. And he said, 2 weeks ago, I felt this lump, this one here. Okay, so this is a photo 5 years ago, assuming that the lump was not there. And 2 weeks ago, the lesion is still there with the lump. Do they progress? Okay, so we have this case. I gathered this photo from the electronic system of that patient, and it appears that he came on 2017 and he was told that this is nothing. So I have a question at the top there. Is it nothing? I've got it in all languages. And here we go. So do you think that this appears, overnight? Does the patient sleep and wake up with this? Or does it, slowly progresses from a small ulcer or the title of the talk, from lesion to malignancy? And patient gets prescribed anything in the pharmacy to help. And here's another one, trying to smoothen the tooth until the tooth is flat, but it's not trauma. Unfortunately, it's not trauma. Smoothen the tooth to infinity. Because we have to highlight that sometimes they are uncurable. So where would you start removing this? The gingiva is involved, the floor of mouth, the ventral tongue, fairly large disease. So the management of leukoplakia, what I'm doing is probably very less aggressive than a 10-hour surgery and post chemoradiation and selective neck dissection and all of the complications that appear after the treatment. So thank you very much for listening to this talk. Thank you very much for inviting me to speak to the Department of Oral Medicine at your university. I have a thank you slide here. I would thank the patients, of course, for allowing me to share their photographs. I would thank the audience listening to me, bearing with me, bearing with my opinion. And I'd like to thank the supporters and my colleagues, obviously, who are referring these cases. And whoever is following my account, I do share cases over there, and some of the news. I'll probably share the poster of this talk today or tomorrow. And probably time to announce that we've recently established the Kuwait Association of Oral Medicine and Facial Pain. This is the first time that this association be established, and I'm pleased to chair this association. Here is my guide. Hopefully, one day I visit the university in Tehran, and I'll bring a few copies for whoever is interested to have a look at this guide. And I'm happy for any questions you may have.
Thank you very much, Professor. Thank you for sharing your invaluable experiences in these uh, clinical cases. Your presentation full of clinical point of view and very uh, well experienced cases. Thank you very much for sharing that. I have only one question. We are open for a question from all of our audience, and I am sorry to say that there are some problems about connection for Zoom in Iran, and some of our colleagues can't enter the room. So we should share the recorded form of your presentation for them. I'm sorry about that. But I want to ask if there is any information about demographic and epidemiology for risk factor in your cases in Kuwait. For example, the range of the age and the gender inclination about these cases, and I heard about some risk factors that you said, but I want to know about the prevalence of use of hookah or, for example, vape in your case. Thank you.
Okay, thank you very much. This is a good question. This is an actual research project that I started in 2023. Now we are analyzing the data for this, and we will obviously know what specific risk factor. But for sure, I can tell you from the patients that come across and from my fairly good memory that smoking, whether it's cigarette smoking or cigar smoking or hookah smoking, shisha smoking, is at the top. Okay, the age group is at a younger level than the worldwide, the known worldwide age group. Okay, so the age group that I'm detecting leukoplakia is in the 30s, early 30s. Okay, so let's say late 20s to early 30s. And this is bad because if you see a leukoplakia in this particular age group in a large number of cases, you anticipate in 5 to 10 years' time, you have a larger number of progression to squamous cell carcinoma if no intervention is happening. So it's scary, but at the same time difficult to control. Okay, so I cannot confirm alcohol being one of the risk factors because alcohol is supposed to be banned here in Kuwait, but people do get it and consume it. But they are reluctant to tell us that they actually consume alcohol. But definitely smoking and and shisha is a risk factor.
Yes. Thank you very much. I'm sure that this is a very well and first step for our good collaboration in all new projects, and we all welcome you to be in our school as our guest. Thank you very much.
Thank you.
Dr. Alsarraf, I want to ask you about AI image analysis. What is your perspective on the role of artificial intelligence in improving diagnostic accuracy for oral potential malignant disorders? Can an AI-based image analysis enhance clinical decision making, especially for oral medicine specialists?
Okay, I didn't expect this question because I'm not interested in in AI. But let me tell you a story which is very recent. It was last week. A patient came in telling me that he's got a potentially malignant disorder, and he was confident that AI told him that he's got this disease. Okay, so from the clinical photo I received on the phone from the clinic, it shows that he's got Fordyce spots, Fordyce granules, the sebaceous glands, we know them, small dots in the buccal mucosa, yellowy dots. Okay, so from the photo, you can see that it might be for these granules, but it's better to see the patient. So I asked the clinic to inform the patient to come to me in the clinic, and I need to see him to tell him what he's got. And he came in with his phone showing me that AI detected his condition from the photo, the same photo that he sent. And the photo he took himself, obviously, a selfie. And I've looked at the AI explanation and diagnosis, and it happens to be that AI diagnosed it as oral lichen planus, and all of the information regarding its malignant potential, and it's bilateral, and it involved the buccal mucosa. You see, like two different conditions. One is purely benign, which is sebaceous glands, and the other is lichen planus, which is debatable to be potentially malignant. And the patient has, raised his level of anxiety and kept doing the medical shopping, consulting, different oral medicine specialists, and used AI. I mean, I know this doesn't answer the question whether it's useful for potentially malignant disorders, but I mean, maybe working at a university. I don't work in a university. I work in the ministry, so I cannot do many projects at one time. But maybe if your department do something for us and publish it, then we will use it to answer your question.
Yes, thank you. And another question is about salivary biomarkers. How effective are salivary biomarkers in identifying high-risk oral lesions? Can they be useful for us or no?
I guess so. The recent research that I came across, the results are promising. Actually, they are collecting those salivary samples and they are comparing them. I guess this topic is promising to detect those biomarkers and tell us which lesion is at least high risk and which lesion is suspicious for transformation, or which certain patients who have these biomarkers are at higher risk.
Sure. Thank you, Professor. On behalf of the organizing committee, Tehran University of Medical Sciences, I would like to thank you for your insightful and inspiring presentation. We deeply appreciate your time and valuable contribution to this webinar. We hope this will be the beginning of continued academic collaboration and more opportunities to learn from your experience in future sessions. Thank you once again, and thanks to all our attenders for being part of this virtual session.
Thank you very much.
Thank you, Professor. This is very fruitful lecture that we have today. Thank you for your time.
Thank you. Bye bye.
Goodbye.